Hannah's going to help me out here. You can hear me now? Okay, excellent. I'm getting nods, so that I'm taking that as a yes. Welcome. All right. So, how is everyone? Good? Good? Excellent. Excellent, excellent. As Diana said, she already knows that I am Julian because she's watched me on the video now for a little bit. For those of you that don't know, I am Julian, and I'm one of the physical therapists here at our practice. And hopefully we'll cover, thank you all for the questions and emails that I got and things like that. So I'm going to make sure that we cover all that here today. If I miss something that you are curious about, you want to know about, not sure about, then make sure we'll have a little Q&A at the end to make sure that everybody gets their information. Janet, for you and anybody else that is there, let's see, we've got somebody else, Cindy. Cindy, for anybody else that's on Zoom, feel free to write in the chat box. We have Hannah is going to be answering those questions, and she can move them along as it will. And if it's something that you want to ask me, she'll go ahead and relay that to me so that we can answer that for you. Okay. And let's see, Hannah, did I get you? Are you? Okay. When you're in, let me know. So let's get rid of this and kind of go through and do a quick little introduction. Diana. All right. I'm just going to go here, Diana. And I met Wendy back there. We've got Larry. And I am drawing a blank. Mary. Mary. Yeah. Mary and Larry.
Angie.
Angie. Welcome, Angie.
Ellen.
Ellen. Welcome, Ellen. All right. So I'm guessing you're all here to learn a little bit more about the knee and how it works, right? So if you wouldn't mind taking just, think about 30 seconds as to a little bit about your history. I'm going to bring this a little bit closer for you guys on Zoom. Hopefully you can see it a little better. Sometimes the lighting is a little bit off. Diana, quick 30 seconds. How long have you been having trouble with your knee? And kind of what does it keep you from doing type of things?
Okay, I injured my knee about a year ago, mountain biking. And though it doesn't have any tears, it is in pain whenever I do any squats or lifting of any kind of weight, like any of my children.
Okay.
And any kind of jumping or pivoting gives it pain.
Okay. Well, I'm very sorry. As a fellow mountain biker, I am sorry. It does happen. Well, welcome, welcome, welcome. And Wendy, what about you?
I don't think I've ever had an injury to it. It's just that in the last couple of years it started to bother me, especially when I'm going upstairs.
Okay.
I hear a lot of crunching when I'm going up the stairs.
Okay.
Sort of like a water bottle that you.
Yeah.
Yeah.
I always refer to that as a Velcro.
So, and I like to spin. I do feel it when I'm spinning also, but it's not aimed to the point where I have to get off, but I definitely can feel it. Like tension on my knee.
Yeah.
And I was told I have a little bit of arthritis.
Okay. All right. Well, welcome. Welcome. And since you're right up here, Ellen, we'll go with you.
Okay. I just have old knees.
Old.
I've had problems for about 10 years. Well,
You said 10 years?
yeah, my left one I've already had stroke like 10 years ago. And so
Okay.
I'm having problems with the right one started for probably about a year ago more.
Okay.
And they both have tears. And maybe
Okay.
they're both going on bone. And I used to do a lot more hiking. And I can't do the fast walking.
Okay.
Wow. That's swollen, so.
That's good. That's good. All right. Well, nothing's swollen, not that you can't do those things.
With a couple of
Okay, hi, welcome.
Last one, huh?
You got one there? Yeah, if we need to pull out some more, we can pull out some more. Thank you, Ellen. Yeah, I'm gonna put you on a hotspot since you just arrived. What's your name?
Stuart,
Stuart. Nice to meet you.
you might remember my wife Nancy. Or
Yes. How's she doing?
she said, say hi.
Oh, well, tell her hi for me. Very good. Welcome. We're just going to round 30 seconds as to how long your knee's been giving you trouble. And for those of you guys on Zoom, I think everybody's, let's see, everybody's on. Looks like everyone's been entered, right? Yep. Okay. Welcome to you guys. If you guys want to just in the chat box, just put down, and Hannah's going to look at it. You know, real quick, how long has your knee been giving you trouble, and what's it keeping you from doing, or what are some of the main things that it's giving you trouble with? So, how about you, Stuart? How long?
Well, I had knee surgery in high school, so it's been a while.
A year ago?
Yeah, probably. Most recently, probably 10 years.
Okay.
Progressive arthritis. I had broken kneecap.
Okay. Okay. Well,
And yeah, now it's, I went to the doctor just a week ago and said, yeah, you're ready for a knee replacement. I said, no, I'm not. I'm going,
okay.
to Julian's webinar.
Okay. So you've been said that you're ready for that, and we'll talk about that a little bit, and hopefully give you guys some insight on that as well. So, well, welcome. I'm glad you came out. Mary.
Yes, you know, I don't think I don't have an injury to my knee, but I had 2 car accidents last year and got rear-ended 2 different times. And I just feel like since then, everything is off. My neck, my shoulders, my back. And there's like a clicking in my knee, like the.
Bit of a clicking in the knee?
Yeah, and it's not terribly painful. I think I'm more scared that something's gonna happen,
Okay. Yeah.
you know, and I don't know. I
Okay.
mean, I've never had problems with my knee.
Yeah.
And it's just really the one side, which, you know, I've had sciatica on that side too.
Yeah.
So anyway.
Okay. All right. Well, welcome. And you brought Larry.
Yeah.
Larry.
He's got all the knee problems.
Larry's got all the knee problems?
I do.
How long?
You know, it's been fairly recent. Like
Okay.
I've had meniscus done like on both knees
Uh-huh.
twice over the years, but it just kind of got it, like, you know, worked great. I ski, and run, and I need, you know, I can't do either anymore very well.
Okay.
In the last year, you know, it's just really, it's a lot, it feels like a lot of inflammation, or it feels like the shock absorbers are like shot.
The shock absorbers are
It's like an
shocked.
old car when you hit a pop.
Yeah.
pothole.
It's abrupt. It's
Yeah.
not smooth anymore.
Yeah.
Okay. All right. Well, let's talk about that. Very good. Thank you. Thank you. And I have Angie.
Yes, so I was a skater like all through my 20s and 30s. And then when COVID hit, I pretty much stopped for probably about 2 years ago.
Skater as in ice skate, roller
derby,
skates,
roller hockey.
roller hockey.
Yeah.
Okay.
Yeah, lots of years. I had a knee surgery on my right knee, the ACL, MCL, and meniscus.
Right knee. Okay.
Yeah, rehabbed it. I was totally fine. But just recently, I haven't worked out in like 2 years. So recently started trying to do like insanity or T25, any of the squats or anything like
Yeah.
that. The day after, I have awful like sharp pains in my knees. So I'm just afraid I'm not doing it correctly, like not strengthening around my knee correctly anymore.
Yeah. Yeah.
I'm afraid I'm gonna do more damage than good.
Sure. Sure. Okay.
Yeah.
Well, we can help you with that. Good. So, welcome,
I'm Lisa.
Lisa. It's been a while.
Yes.
Yeah.
I have a patella that keeps slipping, and I have some therapy. It goes back in the last couple of years. This time it's like not wanting to.
it feels like it keeps slipping. I'm having a lot of pain. I've not been able to exercise, so
Okay.
that makes it hard.
And that's been since December?
Since December.
Ish.
Yeah. I have a history of bad knees in the family. All the women have had knee replacement surgery, so
Okay.
I'm a little hesitant that I might be headed that way.
Okay.
Again, I think it's also a strengthening issue.
Really, yeah, it's very important, very important. And we had somebody come join us at the back.
I'm so sorry I got here late because I can't.
Oh, you're fine, you're fine. What's your name? And just real quick, how long have you been having knee pain?
My name is
Sima.
Sima.
S-I-M-A.
S-I-M-A.
Thank you. And I apologize for my writing, it's not very good.
How long do I have to speak? I fall, I think 16 years ago.
16 years ago?
Yes.
Okay.
Since then, it comes and goes,
Uh-huh.
and almost I can tell, maybe since 7 years, 6 years ago, so probably I fall.
6 years ago, you had a fall?
No, so probably I fall or walking, I couldn't walk.
Oh, you couldn't walk?
Water really got here.
Okay.
Yeah.
Okay. Sounds good. Well, thank you for sharing. And thank you for you guys that put it notes in there.
One more, yeah, Yolanda shared.
Oh, Yolanda shared.
Yeah.
Bothering you for 10 years, osteoarthritis in both knees, hard to walk, stand for a long time, and do have inflammation. I am not bone on bone. All right, we'll talk about that bone on bone. What is bone on bone? So thank you all for sharing. Appreciate that. So the one question that I always like to ask people, we can see here, there's a history that most people's history isn't my knee pain started yesterday. Most often than not, the people that we see, the people who come to the workshop, it's usually I've been having pain for a year, I've been having it for 5 years, I've had it since whatever, long time. That's what we see most common, not only for the knee, but for a lot of things. And we'll talk about that. So the question that I ask is, why are you here tonight? Okay, just to kind of think about that. Why are you here tonight? Yes, you have knee pain, but what is it that brought you on a Tuesday night at 7 o'clock to come listen to this guy who keeps sending you emails? I apologize for all the emails. He said, what is it for you that brought you out here tonight? What is it that makes you want? I know you don't want exercises. Yes, exercise is important, but that typically isn't what people want. What people want typically is, I want to be able to ski. I want to be able to go up and down stairs. I want to be able to play with my kids. Those are the things that typically people want. And those are the things that hopefully we can give you some insight and some information so that you can do. Because I haven't had a patient yet that's come to me that says, I just really want exercises and I'm going to do them all the time. Right? There are a few, but it's most people, they just want to feel better. They just want to feel better, and they want to go about their life, and they want to avoid surgeries, and they just want to feel better. So hopefully we can give you some of that information. For those of you that are at home, you probably got an email to you or mail to you. Everyone should have a worksheet in your, those of you that are here have your folders. You have a worksheet there for you. It's kind of a follow along, kind of keep me on track, make sure I hit all the points on there, and we'll kind of fill it out as we go.
Everyone else kind of shared in the Zoom what their
Okay.
problems are like as well.
Perfect. Thank you all that shared on there, and we'll go through and kind of address them. I see here 15 years of knee pain. Both knees need replacement. There's a lot. Yeah, left knee is bone on bone. Somebody started having pain in November. They have running for 49 years. KT tape usually helps. All that information. Good. Thank you guys very much. Hannah's going to be responding to you guys real quick so that she can answer your questions. And then at the end, we can answer that as well. So Are you guys okay if I put on a face shield? Yeah, you're okay with that? Okay, I will stand back, but sometimes it's easier for you to hear me, even though it sounds like an echo in here, but we can do that. So what you have there on the worksheet, we're just gonna kind of go. So the question is, one of the things is, what is the knee? Okay, so the knee is what we call a hinge joint. Okay, so that blank there is hinge joint. And a hinge joint is like you would see on a hinge on a door, right? It just moves back and forth. So what the knee is really designed to do, so there on B, on letter B there, it's bend and extend. So you can bend your knee, right? You can bend your knee, or you can extend it. You can straighten it out. So those are the things the knee does. It has a teeny tiny little bit of rotation, but its primary function is to bend and to extend. That's what it does right there. And there are two large muscle groups that move the knee. So on the front of the thigh right here, you have your quadriceps muscle. Quadriceps, quad just means four, so there's actually 4 different muscles that are your quads, and their primary role is to straighten your leg, okay, to kick your leg out. Then the other guys that are back here on the back of the thigh, those are your hamstrings, okay? And the hamstrings, there's multiple, there's 3 primary ones back there. We don't need to know names unless you guys really want to know them, but it doesn't matter. Hamstrings back there. And their job is to bend your knee, right? That's what they do. So the knee joint, because it's only designed to primarily bend and extend right there, it's made up of 3 different bones. One is the thigh bone, otherwise known as the femur. The next one is your shin bone, or the tibia. And lastly, it's your kneecap, or the patella, okay? Those are the 3 bones that make up the knee joint, right there. And they're encompassed and surrounded and controlled by these muscles, these large muscles, quads and the hamstrings, right there. If you guys wouldn't mind right now, if you're at home, go ahead and stand up. If you're in here, let's go ahead and stand up for a moment. And what I want you to do is just do a little bit of a squat. Some of you already told me it hurts, so don't force it, but just do a little bit of a squat and see if you feel soreness in the knee. Yeah, I get some nods.
You hear it,
But you get some popping. Somebody's hearing some popping. Yep, that can happen right there. Now, turn your body to the side, facing, say, your left side, and try to do a little squat. What happens to your knee?
Your feet forward?
You can, yeah, keep your feet facing forward and turn your body and try to do a little squat. What happens to those knees? Yeah, don't force it. If you're afraid to do it, don't do it. Don't force it.
Pop even more.
Sometimes there's popping more, sometimes there's more soreness. Pain, yeah, back there, pain when you do that. And you guys can go ahead and sit down. So the knee, being that it's designed to flex and extend, right? Kind of when you're up and down, it's very linear, but we don't tend to move linearly all the time, right? We're continuously, if you're playing with your kids, if you're running, if you're working out, you're usually moving in different patterns. And when you do that, your knee kind of has to follow, right? If you turn your body, your knee kind of goes, but it's really designed to just bend and extend. So what is moving that in that way? What is allowing for the knee to go in different directions if the knee is just really designed to bend and extend? That comes from your foot and ankle, and it comes from your hip, right? And we're going to talk about how important that is, because a lot of times with knee problems, it's not the knee's fault, okay? The knee is kind of stuck in the middle. It's stuck in the middle of the foot and ankle, and it's stuck in the middle of the hip, right? It's below the hip, it's above your foot and your ankle. And guess what? Your hip is kind of your knee, because your femur, that thigh bone, is your hip up here, and down here, it's your knee, or part of the knee, right? So this thigh bone here is your hip and is your knee to a degree. And the shin bone down below you could say is in part your ankle and your knee, because it connects the two. But the knee joint only moves, flexes and extends. Your foot and the ankle, hopefully, can turn, rotate, move all directions. Same thing with your hip. Hopefully it rotates, moves back, moves forward, moves out to the side, does all those different motions. So the knee really relies on the foot and the ankle and the hip in order to help it out. But when its friends back out and they don't do their job, then the knee has to work a little bit harder. And that's usually what starts to cause the wearing down, the breaking down, the meniscus tears, the arthritis, the bone on bone type of thing, is it? How many of you have had x-rays of your knees? Few of you, yeah, few of you. Or MRIs, anybody had MRIs? Yep, few of you had MRIs as well. So the diagnostic testing is kind of tricky because it shows you stuff, but it shows you things in a very static position, right? You're either lying down for an MRI, right? Nobody on this screen, and from what I read from the people online, none of you said you had pain when you were laying down, right? You do?
I get throbbing.
You get some throbbing, okay.
I did too.
Yeah, yep, some throbbing. But most of the pain, the sharp pain, the stuff that keeps you from doing what you want to do is probably not when you're laying down, right? It's stairs, it's squatting, it's maybe mountain biking or whatever it might be. So when you take an image in that position, there's no gravity on there. So there's no compression from gravity. So it's giving you a picture and it gives you an idea of what's there, but it's doing it in a different way. Now they do sometimes do x-rays in standing. Okay, sometimes they do it in standing, or sometimes they do it bent, with your knee bent, because they want to see where that kneecap is, if that kneecap moves, which is good. But most of what we do is dynamic. We're moving, we're mobile type things. Unfortunately, the technology that we have to this day doesn't allow us to take a x-ray with movement or an MRI with movement. So we're not getting 100% of the picture of what's happening in there. And what happens a lot of times is if you take 100% of people that don't have knee pain, zero knee pain, no knee pain, they can run, they jump, they do whatever they want to do without knee pain. What percentage of those people, if they're over the age of 55, have some kind of a meniscus tear in there? Any guesses?
Without any pain?
No pain, zero pain. Zero pain, no pain at all, over the age of 55, 100 people, they get MRIs. How many of those people have tears in their meniscus?
Very few, probably. Okay.
Very few?
A lot of them.
A lot of them. Depending on the research that you look at, it can be anywhere about 78% up to 83%.
With no pain.
No pain, zero pain, meniscus tear. Okay, so a lot of times we end up having knee pain, and then we go in, because we don't typically get MRIs and x-rays when we don't have knee pain. You go in and you get an MRI and there's a meniscus tear in there. And they say, well, you got a meniscus tear, so you need to have surgery to repair that. Sometimes you have to. There are certain tears that you kind of have to get them repaired, or you're going to continue to have pain. Most of them you don't. And the thing that happens, the way we see it all the time in PT, is about 50% of the people that have a meniscus tear that have knee surgery have the same pain, if not worse, within 2 years of their surgery. So I, of course, am a therapist and I tend to be more conservative, but I tell people, do your rehab first. Do what you need to do first, because going in and getting arthroscopically cleaned up, doing a clean out, a little meniscus repair. They used to go in there and remove the meniscus years ago. Years ago, they would go in there and they would just remove the whole meniscus. We've improved on that a lot. I mean, the surgeons are really good and they've improved. So now they try to take away as little as possible. They try to trim it in that area. But when you go into an area that isn't designed to have stuff poking at it, it just expedites the degeneration over an area. So having a knee surgery, I've had knee surgery. I tore my ACL. Okay. So I'm not anti-surgery. There's definitely a time and a place for surgery, you know, and you have to look at the individual and what they want to do and all that stuff. But when people come in with, my knee just started to hurt, and they're having some problems and they have a meniscus tear, I'm very reluctant, unless it's a particular, you know, certain kind of tears, very reluctant to tell people, go ahead and have it arthroscopically cleaned up. Because most of those people, 50%, according to the research, have the same pain, if not worse, within 2 years of surgery. So, not to scare anybody, but just to give you food for thought to think about when you consider your options and what you're doing for your knee. So, again, like I said earlier, my name is Julian. I'm a physical therapist. I've been practicing here. I graduated, fortunately, in 99, so I've been doing it for a little while. And I opened up the practice in Rancho Santa Margarita in 2002. So we've been out here for a little while. And one of the things I noticed when I was in PT school was that certain therapists, when I would go and do my rotations, certain therapists tended to have better outcomes than others. And so I was always like, why is that? Why, you know, you get two patients, they both have knee pain, they go in, they get treated. One person seems to do better than the other, you know, and then you have consistency. Now you have individuals, and there's differences between individuals, but when I consistently started seeing certain patterns, I just kind of started paying attention to what they did. And what I noticed was that the therapists that did more hands-on work with their individuals, their clients got better faster, less visits, and better outcomes. So to me, that seemed reasonable. And so I went ahead and when I graduated and went out, I did a year-long manual therapy course. In our practice, our therapists are manually trained therapists, because I wanted to have better success. And when we looked at it, oops, I have another one there. Initially, so coming out of school with those things in mind, early on, I would see patterns like this, which would be 25, 50, 25% there. So 25% of the people that came to therapy, boom, they got better, 6, 8, 12 visits. They were 100%, no knee pain, good to go, and they were off. Never saw them again. They were great. You had about 50% of the people that did better, got better, but maybe they were like 80%, 90%. It wasn't quite going all the way. And so they were wondering, maybe I need a surgery, maybe I need injections, maybe I need these different things. And they were kind of in that category. And then we had 25% of the people that didn't get better. In fact, sometimes they got worse. I don't know, how many people here have had physical therapy before? Most of you. Yeah. So sometimes, maybe, hopefully not, but sometimes they give you an activity to do and it actually makes your pain worse. Okay. And so these numbers, I didn't like them. They're very, very, very poor in my opinion. But I noticed that the therapists that did more manual therapy tended to have better numbers over here. So that's where I went through that, doing that. Then over the years, I also learned about what we call AFS. I don't call it, they call it. Applied functional science. And applied functional science is what made a big, big, big difference and really changed a lot of our practice. And we've been practicing that way for a good 10 years. 7 years ago, I went through and did a gift fellowship. I'm kind of a continuing education junkie. I don't think that we can ever be done learning. Sometimes it's a review process. Sometimes it's learning something new. And remembering that everybody's an individual, everybody's a little different. So with applied functional science, what applied functional science taught us is what I want you, let's have you guys stand up again for me. And then stand, feet normal, kind of pointing forward. And then I want you to take your right hand and then turn around as far as you can reach. If it hurts, don't do it. Reach as far around as you can. If you're reaching with your right hand and you're reaching all the way around, what's happening on your left foot? Wait. If you reach far enough, do you feel your foot starting to collapse or roll in?
No.
Right? And then go ahead and come back to the middle. And then take your left hand and reach around the other way. And what happens? Right? Your left foot kind of rolls out, your right foot kind of rolls in. Okay? Did I ask you, roll your foot in and roll your foot out? No, right? I just said, go ahead and reach. Thank you guys very much. You can sit down. So that's what applied functional science really started looking at. And whatever part of the body it is, we're talking about the knee, but that knee, my reaching over here with my left hand went throughout my whole body, and it got my opposite side foot all the way down there to collapse in. So one thing that I started learning, something that I felt that we didn't get as much of in school and early on, was really looking at the biomechanics of the body and analyzing that when you work with an individual. I have to be able to see you do what you do to be able to move things. And sometimes when a patient comes in with knee pain, I won't say sometimes, pretty much all the time when somebody comes in with knee pain that is not brought on by trauma. So if the knee pain's brought on by trauma, for me, I was playing soccer, I planted, somebody took my leg out, it was a direct cause and effect. My ACL tore because my body went one way and my knee went the other way, and my knee says, I don't go that way, right? And so the ligaments inside the knee, they tore, okay? But if somebody comes to me and it's not trauma, they didn't have an injury per se, and they have knee pain, I can almost guarantee you that it's not the knee that's causing the problem. The most common two, I already mentioned them earlier, is your foot and your ankle or your hip. But sometimes it's not even the same side, foot and ankle, hip. It could be your opposite side hip, okay? Because when you turned with your hand, that went throughout your whole body. And if my opposite side hip doesn't have the capability, the motion to move, and I'm reaching, it's stopping, maybe that right knee is now taking a little extra load, okay? And you can come and see me and I can rub your knee. If you've been to therapy, maybe you've had your knee rubbed, maybe you've had ultrasound, maybe you've had ice and electrical stimulation or heat and electrical stimulation, and they've made you do straight leg raises, right? Tighten your thigh, make it real tight, lift your leg up, lift your leg out to the side, those things, which are not bad things. I always say there's no bad exercise. There's just a poorly prescribed one, okay? They're not necessarily bad things for you to do, but are they the things that are going to help you get better, okay? If it's tightness in your left hip that's causing your right knee pain, are you going to make your pain go away for good, not just temporarily, because it's easy to make it go away temporarily, right? Pop Advil, put an ice pack on there. If it's lasting a long time, get a cortisone injection, right? Those are all things that we do to kind of decrease the pain, okay? You have to identify the source. And with applied functional science, we've been able to improve to where 90% of the people we see were able to get back to pain-free, okay? So, can't help everybody. I wish I could say that we were 100%, that's not gonna happen, because there are certain things that happen to the knee that need extra help, okay? But what our job is to identify, you know, are you somebody who needs extra help, or are you part of that 90% that can get better without surgery? Or are you part of this 90% that ends up getting surgery because they didn't get the right rehab, and then 2 years later, you're having the same amount of pain? Or 10 years later, they're telling you you need knee replacements because they've caused some irritation and through there, and the degeneration continues to go. So does that make sense? Does that make sense to you guys? Okay, so enough about me. If we're looking at the worksheet here, back to normal. If your knee pain is reproducible, okay, then it's reducible. Okay? As physical therapists, I like it when I can reproduce your pain, not because I like causing you pain, but if there's a movement that causes you pain, then there's usually another movement that can decrease your pain. And if we identify those movements, those motions, then we can get rid of your pain, okay? Which is the goal of what we want to do. We want to eliminate your pain by treating the true cause of the pain and the problem and not treating symptoms. Unfortunately, most practitioners, not just physical therapists, most practitioners, we've become really, really good at treating symptoms, but not necessarily identifying the problems, right? So, and for various reasons, it depends on what you're doing. So we kind of talk about this a little bit. You guys can write it on your own. These are your sheets, but you can just put down in the last 30 days, what's the worst pain you had and what was it that you were doing? I know some of you might say it was stairs. Some of you might say it was squatting. Some of you might say playing with my kids, whatever that is, you can put that in there for yourself. And over there, it has, you know, different things. The most common things we hear: standing, walking, stairs, squatting. Those are, you know, getting up and down from sitting or the bathroom. That's a big one for a lot of people, that they'll have pain as well. Running, lots of runners. I know there's a couple runners already in here, and they have problems with that. So what's the single biggest mistake that people make when it comes to knee pain? It actually carries over to other things as well. Any guesses? Say what?
Not exercising at all.
Not exercising at all. That's a good thing. It kind of falls into this category. The broader, ignoring it, right? The number one mistake that we make if we have knee pain, and other pain as well, is we ignore it. What happens with ignoring it is we're not addressing it. So if we're not addressing it, we're not identifying what's wrong with it. Now, ignoring it doesn't mean we're quiet about it. It can be different things like, my knee's been killing me. You know what? I played football when I was in high school, and I remember I got hit once really hard in my knee, and that's probably why I'm having knee pain now. And I heard somebody say it, I don't know if it was you or somebody else, but another one we use all the time is, I think it's genetic because my aunt had knee pain and my father had knee pain and so on. So, well, it's not contagious, okay? Knee pain's not contagious, fortunately, but it does happen. So ignoring it is one of the things that happens, very, very common. Number two, so if you look down, three things that happen. Number one is ignoring it. Number two is alter it. And number three is handle it. So we talked about ignoring it and what can happen with that, right? It's like a car tire that's wearing funny. The problem isn't the tire. The problem is the alignment, right? The car's alignment's off. I can keep changing the tires, right? But it's not going to preserve them because it's not the tire's fault. It's the alignment's fault. Okay, our body is kind of the same way. It's not the knee's fault. It's what's going on. And very, very common, especially in people when they say you have bone on bone. Most people, if you've looked at your x-rays, for those of you that have x-rays, it's usually kind of tilted in, right? And most people that have knee pain, not all of them, it's usually pain on the inside of their knee, right? I'm seeing some nods. That pain on the inside of the knee, as one, whether we're getting older and sometimes our balance isn't as good, or a huge contributor for all of us is sitting. Sorry, I have you guys sitting right now. But sitting decreases the flexibility in our hips. And when we sit, oftentimes we sit like I see a lot of you with our legs crossed, or we sit with our legs out to the side, right? When we cross them, it kind of rotates our hip out. When we sit with our legs out, they're rotated out. What that does for our hips is it keeps them in this open position, which then makes them tight. And if you do that, then you start seeing that your toes start pointing out. okay? And if you watch people, I'm weird like that. I watch people all the time. Airports are kind of cool because you get to see all kinds of people. But if you watch people, usually the side they have pain on is the side that's toeing out a little bit more. Not always, but oftentimes. And what happens if you're standing and your toe is pointing this way, but you're walking that way? Guess who's getting beat up? The inside of your knee, right? Because your foot's pointing that way, your momentum in your body is moving this way. So the inside of my knee is going to continue to get hit and hit and hit with every single step you take. A lot of people have pain hiking and walking because things are irritated and they walk and it continues to kind of hit and hit and hit. So now, is that the knee's fault? Is a meniscus repair, is a knee replacement going to help the pain? It could temporarily, but why do 50% of those people end up having knee pain the same or worse within 2 years? Is because it wasn't the knee's fault, right? They never addressed, oftentimes, the hip out there. So with sitting, we do two things. One, we get tight, right? We learn these positions that then our body wants to stay in. And studies have shown that people sit for an average of at least 10 hours a day. I will argue that it's more than that. But if you think about the time that you sit on your couch, in the car, at the dining room table, you know, right now as you're listening to me talk, you know, I would say easy 12 hours, depending on how much time you sleep and stay in bed. And then when you're asleep, so many people are side sleepers, right? Most people sleep on their side. And what happens when you sleep on your side? You tend to sleep in the fetal position. And where are your hips? They're bent. And what does that look like? That looks the same as you sitting in a chair, right? You're bent forward, you're laying on your side, holding that pillow right there. It's the same thing when you're sitting up and your posture is broken down, leaning forward. You're just doing it on your side. So gravity's not pushing on you, but now you take this body and we wonder why our shoulders start to round forward and why we kind of start to slouch and why our steps get shorter. Because when our hips are really, really tight, it's hard for my hip to extend, right? And so what do I do to bail out when my hip won't extend? I rotate my foot out, especially I start walking faster. Who was it that said that when they walk faster, it starts to hurt? Was it you? Somebody, oh, you said. Yeah, the faster you walk, the longer your stride. The longer your stride, the more hip flexion, or sorry, extension that you need to have. If you don't have that hip extension, you're going to get it from somewhere else. And it's usually collapsing your foot and rotating your hip out in order to do that. So you develop this little heel whip type motion where your foot rotates. Okay, and you can see it if you look at your shoes and how they wear. Okay, that's one of the things we'll look at. Usually I tell people, bring your old pair of shoes. What shoes do you walk in? What shoes do you run in? What shoes do you stand in most of the time? Bring me those shoes. I want to see those shoes because that tells me a lot about how you're moving. Okay, your wear patterns. Where do you hit? Where do you push? Where do you roll? That it's a quick indicator. It gives me an idea. Doesn't necessarily give me all the answers, but it gives me an idea of how you're moving. But I want to definitely watch you move, because if I don't see you move, then I'm not going to get the information that I need from there. Does that make sense? Yeah, making sense? So altering it. How do people alter their pain? We've already talked a little bit about it, right? One way that people alter their pain is medication. Super, super common, probably one of the most common. Medication. Injections, another way people alter the pain. Not getting rid of the problem, it's decreasing the pain, right? Taking care of the symptoms for a while. I get people all the time say, well, I just go in for 2 or 3 shots a year and I do okay. Okay. The problem with those shots with cortisone or steroid-based injections is that they weaken ligaments and tendons and they expedite the degeneration of the cartilage. So the more injections you get, the more you're wearing down your lubricant, basically the white cartilage, the smoothness. You can't see it very well here, but the smooth part of the bone right there, which glides over the meniscus, you're starting to create little divots and little bones. And you get x-rays and they go, ooh, right there, you've got little bone spurs. And you've got little chips in it, and that's probably what's causing your knee pain. And it probably is part of what's causing the knee pain potentially. But cortisone and steroid injections expedite that process. Okay, so sometimes you have to, and sometimes it's necessary, but if you don't have to, you want to try to avoid injections when you can. Cortisone injections anyway. Another way that people alter it is they'll put on a brace. Another real popular one these days is CBD or other creams. Rub it, lather it. It can help, right? But it's not taking care of the problem. The most common thing that people do that always gets me, because you don't necessarily have to do this, is I have a runner or I have somebody that likes to walk or hike, right? And they do it 5 days a week, 5 times a week, right there. And what do they start doing? Is now they only run 3 times a week. Because it hurts when I run 5 days a week. I need that day off in between to recuperate. Okay, and now I'm running 3 times a week. And I like to run marathons, not me personally. I like half marathons personally, but and then all of a sudden it's like, well, I don't need to be a marathoner anymore. I can run, half marathon's fine. Then pretty soon that half marathon becomes a 10K. And then that 10K becomes a 5K. And then that 5K means, you know what, running, I don't need to run anymore. Now I'm just gonna walk, okay? This is the most common. And if you keep on this path, pretty soon all you're doing is what's killing us, which is sitting, right? It hurts to play, it hurts to run, it hurts to hike, it hurts. So you start decreasing your activity level. And that has its own consequences, and we don't need to go into all that. But that could come from something as simple as having knee pain, which seems simple, but it's not always that simple, right? So very, very important to remember that. You don't have to do this, right? Sometimes you do, and sometimes you have to modify things, and it depends on when we see people, how far along they are with what's been going on, but you don't usually have to do this right here. Think about what you like to do, and let's figure out a way for you to be able to do that. So the third thing you can do is handle it. How do you handle it? You figure out what the cause of it is, right? So you got to identify what is causing it. What's bone on bone? Is bone on bone truly that everything's completely gone? Well, if it was, you wouldn't be walking because your joint couldn't move. If it was bone on bone, it would be excruciatingly painful because it wouldn't have any movement at that point in time. So bone on bone usually means there's different grades of it, right? There could be different severity, mild, moderate, or severe, right? But a lot of times they'll just say, oh, you're bone on bone. Well, what does bone on bone mean? Where am I bone on bone? Am I bone on bone when I'm standing, or when I'm laying down, or when my knees bent, or when I'm squatting? When is it bone on bone? Probably not like that all the time. So we got to take a look and see, are there things that can change it? We have people that have come in that have bone on bone that we're able to work with and are able to get pain-free and get back to doing what they want to do. Okay? It's identifying what's causing the misalignment, because it's usually a misalignment. Could be, and we'll talk, because strength is a big contributor, right? It's not just tightness. Lack of strength could be an issue too, right? So looking at, so we want to handle it. We want to identify what's going on in order to take care of the problem. So the top 4 causes of knee pain are there is ligament sprain or tear. So a sprain or a tear of a ligament. A ligament connects a bone to a bone. So if we're looking at our guy here, this is a right knee, and this right here would be a ligament. It's connecting the thigh bone to the smaller bone over here, your fibula on the side. On this side, you have it connecting from the thigh bone to the shin bone right here. And then inside, you have 2 of them. That's where your ACL, we hear about that all the time, your ACL and your PCL, so your anterior cruciate ligament and your posterior cruciate ligament are in there. And they get disrupted when something rotates faster from the top than the bottom, or if the top's fixed, rotating from the bottom to the top. So when the cause of the pain is a ligament, sprains can heal. Okay, so that's good. Sprains can heal. You have to give them the right environment. You have to see where they're at, take stress off of it. Sometimes it requires rest. Sometimes it does require medication to help things calm down. But you want to take stress off of that area and you want to let it calm down. If it's a tear, it's going to, for the ligament, it's going to depend. Is it a partial tear? Is it a full tear? When mine happened, it was a complete tear. My ACL was gone. Okay, it was gone. So I had a choice. Do I want to live without my ACL or do I want to have surgery? That was my choice. I was 21 years old at that time, 22, sorry. I was in physical therapy school and I decided for what I wanted to do, the activities I want to do, I'm going to get that repaired. So I went ahead and had surgery to have that repaired. Is that going to cause my knee to wear down a little faster? Probably. If I can maintain the stability and the strength and the flexibility on the muscles around there, does it have to be? No. Okay. So I try to do my part for myself and work it as much as I can. And I've been able to run, right? You had ACL surgery. Yeah. I've been able to run, surf, hike, snowboard, whatever it is, since I had that surgery without pain. Okay. Fortunately. Unfortunately, there are people that I see that have had ACLs, reconstructions that continue to have pain. They took care of the broken structure. They put in a new one. When it's trauma, there's a cause and effect, right? So we know this happened, that happened, there was a tear, we repaired it. But if they've developed compensatory patterns, if they decided to wait a long period of time before having their ACL reconstruction or what it might be, whatever it might be, they might develop compensation that then puts extra stress through that knee area. That won't necessarily damage the ligament, but it continues to cause pain from there. So even though the structure has been repaired, they still have pain. So that's a ligament. Meniscus, we talk about meniscus. We hear a lot about meniscus or cartilage damage, degeneration in the knee. So the meniscus is inside. You kind of refer to, you feel like you've lost your shock absorbers. The meniscus provide some cushion in that area, but over time they can kind of wear a little bit. And like I said, take 100 people without knee pain, you're going to get somewhere in that 78 to 82% of people without knee pain over the age of 55 that have some tears in their meniscus. Okay, it doesn't have to be the cause of it, of the pain, but it can be there. They can go in there and they can come out. If there's a big, what we call like a flap tear of the meniscus, you have to get that repaired. Okay, they have to go in there and get it, because what happens is it's too big of a flap and it catches in there. People that have that problem with the meniscus usually will have it where they're walking or they move a certain way and their knee locks and they're like, oh, that really hurts, that really hurts. And they kind of jiggle it and move it and it clears and they're like, wow, that really hurt. And then they continue doing what they're doing. Okay. And they can start locking up like that and create a bigger tear. So if that's the situation, when we see people and we run them through the functional tests that we do and take a look at them, that's the issue, then they need to have surgery. Okay. We're not going to make that go away. But most small tears of the meniscus, they don't have to be a problem. They don't have to be the cause of your pain. Okay. Because if you have the muscle supporting the area properly and your alignment is moving correctly, you're not going to have that extra stress over the area that's been getting worn, right? You won't have that problem. So meniscus, arthritis, that's a very, very common one. That's usually the result of degeneration over time. Arthritis, arth means joint, itis means inflammation. So arthritis just means inflammation of the joint. It doesn't tell us what's causing it. It's just telling us that there's inflammation in the joint. A lot of times it's that degeneration, wear and tear over time because of malalignment, kind of going in through those areas that the same area gets kind of hit, or multiple cortisone injections over time. That can cause some of that wearing in there as well. So That's arthritis. And then D, problem in the foot or ankle, hip, which we've been talking about, and even in the lower back. Sometimes pain in the lower back or a problem in the low back can be what's causing pain in your knee. We call that referred pain. So again, it's one of the things we look for when we screen people with some special tests and things that we do to identify, is the knee pain really knee pain? You know, is that where the pain is, or is it coming from somewhere else? And then identifying, is the knee pain caused because of the knee, or is the knee pain caused because another structure in the body is not contributing, not doing their part to let the body move normal? Make sense? Yeah? Okay, good. So what does successful, non-invasive, natural treatment look like? Hands-on physical therapy to move the knee and surrounding joints, okay? When you've developed compensation for a long period of time, the muscles aren't doing what they're supposed to do, okay? You've got a certain area that's probably too weak, that can't support it. You probably have an area that's too tight, that's wanting to dominate it and pull things in a certain way. So you have to get in there and you have to manually. Exercises are really good. And we're going to talk here. B, the next thing is strengthening and stretching exercises to retrain the muscle memory, right? But if you're doing the exercise and your body doesn't know what to do with it, it's not going to help it, okay? We're not going to help it sufficiently. So we want to make sure that it's the right exercise. And each one of you is different. So each one of you may have weakness in a different area. So a lot of times people say, can you just give me 3 exercises to do for my knee pain? I can. I can give you 3. I could give you a lot of exercises for knee pain, but I don't know if those are the best exercises for you. And for those of you that have been to physical therapy, a lot of times, historically, is you get a sheet of paper. Kaiser's really good at this. You get a sheet of paper, not, bagging on them, but you'll go to therapy, you'll show up to therapy, you'll have a therapist do an evaluation. They'll quickly look at stuff. They might check your strength. They might have you walk. They'll look at it. You'll say, yep, you came in with an order for knee pain. You have a meniscus tear. Here's your sheet of exercises for a meniscus tear. Right? I see nods. So now, how do I know that her meniscus tear has the same structural issues as yours? Right? I don't. Unless I'm really looking at you and saying, let me see you do what you do, and let me see you move like you move. And then that's going to show me where I might be able to place my hands and change it and say, hey, what happens if I do this? Oh my goodness, I have no pain. Okay. Well, if you have no pain when I'm holding you in this position, my job is to figure out how I can train your leg by showing you what you need to do to make sure that that structure stays in that position, right? And we are very fluid. People talk about neutral. It's usually not about the knee, but they'll talk about neutral spine, right? You want to stay in neutral. You want your belly button towards your spine. You want to engage your abs. Have you guys tried walking around like that? Right? Like a robot trying to do that? We don't. And then the moment you start thinking about a task, you completely forget this and say, I need to pick up after my kids. And you dive down to do it and neutral's gone, right? So with AFS, we say neutral is not a position you maintain. Neutral is a position you go through. So you need to be able to go through neutral. You need to have the capability of the joints and the structures to be able to do it, but you don't have to necessarily maintain it, because otherwise you would just be static all the time. Right? So we want to be able to move. So the right strengthening and the right stretching exercise for that individual. We want to identify, is it your hip flexors? Is it your quads? Is it your calf? Is it your opposite side shoulder? What is the structure that's changing the way you move? If we can identify that, then we can show you what to do. Then it's up to you. Therapy is only as good as your compliance, right? You can come and see us 1 day a week, 3 days a week, 5 days a week. Nobody really comes 5 days a week, but you could. But if you're not doing your work at home, it's not going to work. Okay, so we can facilitate things, but you have to do your part. My job, our job as physical therapists is to identify the structure, the joint, the bone, the muscle, the ligament that is not moving properly. Shouldn't say ligament because the ligaments don't move consciously, right? They're just in there to support. But identify what's not moving correctly and to show you this is what you need to do to get this structure over here to work. And that exercise better start to look kind of like what you want to do. If you want to squat, the exercise I give you should have components of squatting. If it doesn't, if I'm giving you a straight leg raise, pretty hard to squat with your leg completely locked out straight, right? But it's not going to do me a lot of good to strengthen my leg with my knees completely locked out if what I want to be able to do is squat. That's a completely different movement. If you want to get really good at kicking the ball and having your leg completely straight, okay, that's a good exercise. Let's do that. But if you want to run, that's a terrible exercise. I'm asking a muscle to overload itself when it's not used to working that way, right? When I run and I come down, guess what? All of these muscles fire at the same time. So if I'm breaking it down and isolating one muscle group independently of all the others, I'm not helping you with that task completely. It can be a component of it, but it's not going to be specific to running or biking or stair climbing or anything like that. So we've got to look at things breaking down where we're working all the structures at the same time. And we got to identify that. Sometimes we do break it down into components. I want you to be able to do this part or that part, right? But the only people that really need to isolate out a muscle and really work a muscle is a bodybuilder that wants that one muscle to pop. So then, great, really isolate that muscle and work it really, really, really hard, and you're going to get that. For most of us, if we just want to be functional and doing the things we want to do, that's not the best thing for us to do. Okay, it can be a component of it, but it better not be the bulk of what you do. And if you've gotten that sheet from a place like Kaiser or somewhere else, you probably have a lot. Can you stand on one foot and balance? It's not a bad exercise if you want to be a flamingo, right? It's pretty good. But if you want to be able to walk, standing on one leg like this isn't really working the muscles in the way they work when I walk. Does that make sense? Yeah. So strengthening, the last thing we have on there is class 4 laser. We use a class 4 laser. It helps expedite the healing process of tissue. It's FDA cleared. It helps. So questions I usually get is, what do you think about PRP? What do you think about stem cell? Because those are things that people are doing. Laser kind of falls into that same category. It's something that stimulates your own body's healing response. That's what PRP is. They draw your blood, they spin it, they take the plasma out and they re-inject it into the area, whether it's the meniscus, if they want the meniscus to heal, or cartilage, if they want cartilage to fill in. They're injecting those things in there to stimulate your own body's healing response, to try to make it go faster. Stem cell, PRP, laser stimulates your body's own healing response. Okay.
Do they work?
Do they work? They can. We've had really good. The one that shocked me is laser for people with arthritis, people that have arthritic pain, sometimes coming in with bone on bone type pain that they've been told. The laser helps and can reduce the pain. Done in and of itself, it becomes, and we have it here and we do it all the time, but if somebody comes and says, I only want to do laser, I'll say, okay, but let's take a look at you first. Not that the laser can't help decrease the pain and inflammation. If it's a meniscus tear, a ligament that's torn, if it's tissue that's been damaged, laser work awesome. Really, a hamstring strain, calf strain, plantar fasciitis, things like that, works really, really well because it's helping the body heal those tissues. If you have a lot of degeneration and mechanically you've changed the way you're moving, it can help decrease your pain and it can help repair the things that are kind of irritated, but it's not going to do you much good because you're going to continue to irritate them with doing the things that you're doing. So I tell people you can use it as part of your rehab to help you get there faster, decreases the number of visits that it takes, it helps you do those things. But don't do it in and of itself. Let's find the structural thing. If we can find the structural thing that's not working right and do that, then that will help heal things and make the pain go away. If you want to make it go away faster, use laser along with that, and then that's going to help you out and go faster. So, questions. Now, we've been talking here, and I apologize. I usually try to keep it an hour. We're a little bit over the hour, so I'm sorry about that. There's questions that always come up. One of them is the PRP, stem cell injections. Sometimes people get other kinds of injections, which are hyaluronic acid or Synvisc. It's kind of injecting in there, creating a coating. It's kind of creating a coating over that cartilage to try to make things glide a little better. It can be effective. It's also kind of cycles through, 3 to 6 months, depending on the individual. Some people get it for longer benefit, and then it usually comes back. Any of those things, sometimes when people are really, really acute and irritated by something, a medication, an injection, something like that is not a bad idea to calm things down so that then we can get them moving properly. So that's sometimes the case. But what happens most of the time is people get an injection, and if it works, they go, boy, I feel really good. I don't need therapy. I'm done. I'm out of here. And that's okay, but then we'll see them 6, 8, 10, 12 months down the road with a similar problem.
What about over the counter, like glucosamine, chondroitin?
Yeah, glucosamine, chondroitin can be something that can help. Usually the studies, I must say I haven't read any of the recent studies. I've read studies in the past. Usually you have to take it consistently for, I think it was at least 3 months, consistently for at least 3 months to notice a change. I tell people take it. It's not going to hurt you. From everything I've read, it's not going to hurt you. But
share something. I was taking it for years.
Yeah.
And I quit taking it just for Thanksgiving. And after 3 months now, my knees are swollen.
you notice a difference.
Oh, yeah.
Yeah.
But
Yeah.
I started
So
taking it.
I would start taking it again. Yeah. Another thing that sometimes people take that can be helpful is omega-3s. The right omega-3s. Omega-3s are a natural anti-inflammatory. So not only does that can help your cardiovascular system, it can help your joints as well. Those are some natural things that you can take. Other people like turmeric as something that they can take. There's a variety of things. Some people respond well to things, some people don't, just like everything else, right? Some people do great with an injection, some people don't. Some people, they get one stem cell treatment and they're like, wow, this is magic. Some people don't do those things. So another question that always comes up is, if I want to have treatment, what do I need to do? I'm going to give you guys a couple options. If we do take insurance, not if we do take insurance, certain plans, we don't take all plans. We're not contracted with Kaiser. Kaiser is their own world. They like to do everything on their own, which is fine. If you've had Kaiser treatment, you know what Kaiser treatment is. They do very, very well for a lot of things. Just physically, yeah, I saw this from somebody. For my in-laws have Kaiser, not bashing on Kaiser. They're really, 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 really good if you're having a life or death situation. Okay, fabulous. My father-in-law, quintuple bypass, heart attack, surgery, boom, 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 covered everything, took care of them, done. If you have knee pain, they're not usually very good at it. Can't say they're not good at it. They're not very responsive to it. They just kind of let you do it. Here's a sheet of paper, go to physical therapy, see you a couple of times. Here's your sheet of paper, do these exercises, come back if you have a problem. Come back. If you bug them long enough, they might give you an injection or some medication. To get surgery, you have to really, 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 really bug them in order to get surgery and down the road. Yeah, so anyway, a lot of the HMOs, a lot of Kaisers, they work in that way, unfortunately. So we are not contracted with HMOs. We are not contracted with Kaiser. We have different self-pay options for people that have those plans and want to see us. They're tired of their pain. They've been dealing with you know, their particular plans or their particular payers or caregivers. And, you know, now it's been a year, it's been 2 years, it's been 10 years, and they want to get rid of their pain. They don't really care that much about their pain. They just want to be able to do what they want to do. They want to be able to hike. They want to be able to run. They want to be able to squat. They want to play with their grandkids. That's what people come to us for. They usually say, I'm coming for physical therapy. If you're honest with yourselves, you don't want physical therapy. You don't want surgery. You don't want an injection. You don't want chiropractic care. You don't want to see the doctor, right? You just want to feel good and you want to do what you want to do. So for people that have that, we do have some different self-pay options available for that. For people that we are in network with PPO, what is it going to cost you? That depends on your insurance plan, right? Some people are $10 copays, rare these days, but it happens. Some people, you know, it's an $80 copay. We can check that for you if you want. Medicare, if you're straight Medicare, regular Medicare, we are contracted with them and they do cover it. So we can check on that for you. The most important part that I tell people is, do you want to get better? If you want to get better and you want to give yourself a chance, I would say try it. And because of that, because you guys are here tonight, whether it's via Zoom or here in person, we have two options for you. Some of you are like, okay, I'm tired of it and I just want treatment. I want to start getting back to normal. And what that looks like is it's an initial evaluation. That's a 1-hour session with one of our knee pain specialists, one of our doctors of physical therapy. They're going to take a look at you. They're going to watch you move. They're going to check your strength. They're going to check your nerve health. They're going to do some special tests for you. And they're going to identify what the true cause of your pain is. You know, if it's biomechanical and if it's musculoskeletal, meaning if it's related to your muscles and your bones and your movement anatomy, we can help. And if we can't help, we're going to tell you. Okay. No, I wish I could help you, but unfortunately, and if we can't help you, we're going to tell you where to go. Okay. I'm going to give you the option. I'll tell you. We're going to say, hey, you know what? You probably want to go see this practitioner or this type of practitioner in order to get some help. So initial evaluations, you can go through insurance or you can do a self-pay option. You guys that are here, our normal self-pay option for an evaluation is $160 for that. For people that attend the workshop, Zoom or here, we discounted. If you schedule your appointment tonight, it's $125. Okay, so we give you a pretty good discount because you guys have put up with me for now an hour plus. You've listened to me. So if you want to do it that way, you can do that if you schedule your evaluation tonight. If you have insurance, we can go through your insurance. It's going to depend on deductibles and co-pays and co-insurances and all that stuff, but we can figure that out for you.
And insurance, need to get a prescription first for it?
Good question. Thank you for bringing that up.
Yeah.
Do you need a prescription for physical therapy? In the state of California, we have direct access or a form of direct access, meaning that an individual can come to physical therapy without a doctor's prescription for 12 visits or 45 days, whichever comes first. So most insurance companies abide by that. Some of them don't. If you have Kaiser, if you have an HMO or anything, you're going to need a referral, and that they're only going to refer you to their practitioners. So it won't be here. Medicare, you do not need a prescription for Medicare. Medicare just requires a signed plan of care, which is when you come in and we do that evaluation, we write up that report, we'll fax it to the doctor of your choice that you want to send it to. And then if they agree with what we're putting out there as the plan for you, they'll sign it off and that's your prescription. That's all that's required. So you don't have to go in. But most insurance companies, I'd say about 95% these days abide by that, and you're able to get physical therapy without a prescription for 12 visits or 45 days, which is usually more than enough to figure that out. Most people don't need more than that, but that's an option. So thank you for bringing that up, that question. Good question. So that's option number one. Number two, so that's for somebody that's, I want treatment, I want help, I want to do that. Now, That's going to be some of you. Some of you are like, yeah, this sounds good and all, but I'm not sure if this is right for me. I'm not sure if I can. I'm not sure, you know, you're not with my insurance, blah, blah, blah. All these different things that go through our heads. I always tell them, why are you here? And the reason you're here is you want to be able to do whatever it was that you wanted to do that we wrote up in the board. But to make it easy, we do what we call discovery visits. These discovery visits are free. They don't cost you a penny. And we do this for the people that attend the workshops, that register for the workshops. We give them this ability because if they're doing it, people don't come for us for fun, right? They come to get better. They're having something that they want help with. And so we want to do that for you. And we do that for the community, for people that register for the workshops. What that is you're going to be with one of our doctors of physical therapy for 20 to 25 minutes. They're going to go through all the same assessments, checking movement, strength, the whole bit, talk to you about what your goals are, and they're going to identify what the true cause of your pain is, and they're going to come up with a treatment plan. So all of that is the same as the evaluation, but then that's where the discovery visit stops. You don't get any treatment that day. So if you do an initial evaluation and everything, you get you get treatment, you get going that very same day. If you do a discovery visit, you don't get any treatment that day. You get the whole plan and everything, but you don't get treatment. So if you're here, I would say you want one of those two options because you're tired of the pain or you wouldn't have come, right? You want some help. So who here in the room, and if you guys on Zoom, you can put in the chat, if you want an initial evaluation, we have some spots that they blocked out for people that come to the workshop. If you want an initial evaluation, is anybody here want an initial evaluation? You want an initial evaluation? You want it? Okay, so let's not overload the ladies. Rachel's up there. Go ahead and talk to them and they'll get you one of those spots. You want it, one, two, these? You go talk to them. You want initial evaluation? Okay. That's the initial evaluation. That's, you want treatment that same day. That one's going to be either a self-pay option or an insurance option that we can give you kind of that information from. So those are the people. So for you guys, I'm going to answer any questions you guys have. And so you guys are more the discovery visit. Okay, the discovery visit doesn't cost you anything. Okay, you guys have been through whatever treatment you've been through. You know, most of you or multiple of you have said that, and sorry, Zoom people, I'm not ignoring you. I've just got the people in here. So if you're on Zoom and you want a discovery visit, put down discovery visit in the chat box and Rachel or Hannah will give you a call. It'll probably take a few minutes because they're handling the people that are in here. But if you want a discovery visit, put it in the chat, discovery visit, and they'll give you a call. If you want an initial evaluation and you're on Zoom, put down initial evaluation and they'll call you and they'll get you in there. So one of those two. For those of you guys that are still here, what questions can I answer for you? What other questions do you have?
You were distinguishing between functional pain or injury pain. I have injury. So where does that put me as far as eligible for PT or not?
Okay, so if I'm remembering correctly, your injury pain was from a mountain biking accident where you fell about a year ago. Okay, so that one we have to check out and see, because if it happened a year ago, whatever trauma happened, whatever injury happened at that time, should have more than recovered by now. Most injuries, if you have an injury, a sprain, a strain, anything like that, and you're not compensating, most of the time your inflammatory stage where things are really pissed off, swollen, irritated is going to be the first 7 to 10 days. Full healing should be in about 21 days to 28 days, depending on what you read. So within a month, an injury should have resolved if we've given it the right environment and if that's what the cause of it was. If it stimulated other things or, you know, life forced you to do other things, then we have to look and see if it's biomechanical. A lot of times with an injury like that, and we can talk more specifically. I would definitely say do a discovery visit. It doesn't cost you anything. Let's look at it and see if it is something that's biomechanical and functional. If it is, we can help you with that. If it's not, we'll tell you. where to go. But good question. Yeah. During the assessment, we'll be able to tell if it's biomechanical or not. Yeah, good question.
No questions, just one final?
You want to sign up? Okay. We're gonna give them just a couple minutes. They're handling there, so they don't get overloaded over there. Do you have a question?
Okay, discovery, maybe I was suggesting, discovery is, I know, actually, initial assessment would be.
Mhm. Yeah, the discovery, yeah. The discovery visit, you're gonna meet with one of the doctors of physical therapy for about 20 to 25 minutes. They're gonna run you through the assessments. They're gonna look at everything. They're gonna come up with what the cause of your pain is. If it's biomechanical, we can help you with that. If it's not, we're gonna tell you that. If you need extra, if we can help you, we're gonna tell you what that treatment plan looks like. You know, for you, it's gonna be one visit. For you, it's gonna be 18 visits, whatever it might be. At that point in time, you can decide, hey, I want the help, or no, or hey, we have people sometimes that come in, do the discovery visits, and they wanna take it to their in-network provider and go get their physical therapist in network to help them out and have that information, and that's perfectly good. But our goal is for you to get the help you need. You wouldn't be here if you didn't need help or want help. So we just want to help guide you. If you've tried your other avenues and it hasn't been successful because of whatever reason, then and you want to get better, then I would say give it a shot. But the discovery visit will give you that, hey, can we help you or not? And here's what the treatment plan looks like. And then at that point in time, you can go with it. Yeah. Decide. Any other questions? Questions back there? No? No. Okay, good. So you want a discovery visit? Okay, so go ahead and talk to Hannah or Rachel. You're gonna get one too? Perfect, perfect. It doesn't cost you anything. So I always tell people you have 0 to lose, a lot to gain. What's that?
For 28 minutes, for the discovery visit?
20 to 25 minutes. That's a discovery visit. There's no cost to that. If you want treatment, then that's the initial evaluation.
How much it costs, how many
Yep,
times.
they can give you all the options. Yeah, yeah. The first thing, if you're not ready for it, the first thing is come in, do the discovery visit. Let's see if we can help you or not. Once we decide that, then they can give you all of your different options, you know, because we have packages that'll help discount costs for you if you're a Kaiser or HMO or you're a HMO, yeah.
You don't accept them.
No,
You don't
we
accept
don't.
them, yeah.
And unfortunately, in your package, you have it there. Unfortunately, we don't take certain HMO plans and certain things because it doesn't allow us to have the time to take care of you. We block out, we see our clients for 30 minutes, 1 hour on the initials, and then 30 minutes for the follow-ups. Usually it might be 30 minutes with us. A lot of times, places that have certain contracts will see people 3, 4, 5 patients an hour. I can't give you the treatment that you deserve for that, but I can't do it for $45 either. So that's why we have to be selective with some of the plans. We want to make sure that we provide you the service that you deserve.
I just want to know that what kind of PPO do you guys take?
What kind of PPO do we take? They can tell you which PPOs we take. Yeah, they can give you all that information. Yeah. Yeah, you're very, very welcome. Thank you for coming.
Okay, so another insurance question.
Yep.
I'm not completely well versed in this all, but
That's
I'm
okay.
Medi-Cal right now.
You're what?
Medi-Cal.
Medi-Cal? Yeah, we're not
Yeah,
contracted.
I figured, I assumed,
Yeah,
but you
yeah.
know, gotta check. Just need
Yeah,
to-
no, absolutely.
Okay.
Absolutely.
So I had an MRI and I've been digging into the info about this for a while as to like what's going on there.
Yeah.
And I definitely still have injury.
Yeah. So what we have to look at is to see, so you had a mechanism, you had a mountain bike injury where you injured your knee. It got angry, upset, irritated. If there's still injury, so bring your MRI report with you.
I mean, I could rattle it off. I know what
Okay,
it said.
what does it say?
I mean, it said there was a bone marrow edema
Okay,
and an extrusion of the meniscus,
okay,
but no tears anywhere.
okay. So the meniscus just kind of moved out of position a little bit.
Right,
And there's the bone edema is just from the contusion.
right. And
So-
I think there was also a tear in the cartilage on the femur.
Okay, yep.
So
And
I'm
that's
not sure
probably
how
where the
long that,
impact
if,
was.
like, I've seen
Yeah,
information about cartilage not healing like ever.
yes.
And also,
It's
you know,
very slow at healing, and if it keeps getting the same stress on it, then it's not gonna heal.
right, so
Yeah.
that's kind of where I'm at, where like
Yeah.
I'm trying to, you know, not do anything, because I
Right.
don't want to stress it out, because when I do, I feel the burn, and it's
Right, and it's been a year, and you're tired of it, and you're, you know,
in the meantime,
not
like all my
99,
muscles are
so-
wasting away, so
Right.
I'm like, I gotta do something.
so we gotta come up with strategies for you. There's
Yeah.
a few different things that we can do. We can look at, you might be a good candidate for laser,
That's what I was
because the
thinking, I was
laser
talking about
really
it.
stimulates, so for that bone bruising and the
Yeah.
edema, laser, and for the fusion of the meniscus, that can be very, very
functional thing,
helpful
right?
for that.
Okay,
Yeah, that can be very
Alright.
helpful for that. But do at least the discovery visit so that
Yeah.
we can identify what's going on. That can totally be something for you, but we'll see how to best help you out.
okay.
Okay.
Awesome. I'm gonna talk.
Yeah, yeah.
her and get started.
Perfect.
Thank you so much.
You're very welcome. And for you guys that have been so good in listening to me, any questions? Let me see if Janet, you're muted. Let me see. Can we unmute you? Let me see. I apologize. Let me see. I think it might be Hannah. Hannah might still have control of my computer, and she might be the one that's why I can't unmute you. Let me see. Hold on one moment.
Is that better?
There we go. I got you.
Sorry, I'm doing this on my iPad, so I didn't know that I could chat. This is my first time on Zoom.
Oh, well, congratulations.
I didn't have a camera from my desktop, so
Okay. No.
so anyway,
I'm gonna roll you here with me, and I'm gonna bring you here. Can you see me there?
yes.
All
yes.
right, perfect. How
Okay.
can I help you?
Well, I would like, I don't know which to do, the discovery or the consult.
Okay.
So,
Tell me a little bit about what's going on, and then maybe I can help guide you.
oh, just I had meniscus surgery years and years and years ago. And so now they tell me it's bone on bone.
Okay.
And I know I have really tight muscles and I've got to start working on it. And I know I have back problems. So I don't know whether, you know, but I don't want surgery.
Sure.
So I
Yeah.
really don't want surgery. So
Yeah.
anyway, I have an HMO, unfortunately. So
Okay.
I would have to consider the price of everything.
Sure.
But I don't know for me if it'd be better to go ahead and do the consult
Mhm.
to get a better idea of things.
Yeah. So the consult is a great option to kind of give you, this is what we can do for you. If you want to take advantage of the discount that we have tonight for attending, then that would be tonight, and you would get treatment that same day. And that
Okay.
would be 125 instead of 160.
Okay.
Our normal 160 would be 125. But if you're, not sure about it and you want to do the discovery visit, that's, either one,
Okay.
you're not going to go wrong. In the
Julian,
sense
well, so then for the treatment, you have package plans
that-
for the ongoing treatment?
Yep.
Is there any
Yeah.
idea of how much? I mean, is it,
So
is
look
it,
at it. So our regular, so you get to choose at that point in time. If you want
uh-huh,
a full hour with the therapist, it's that 160 rate. If you want
okay,
a 30-minute session with the therapist, then it's a $100 rate.
okay,
Those are our regular rates. If you
Okay.
buy 6 or 10 of them, then there's discounted rates.
Okay.
If you get 10 of them, if I'm remembering correctly, and I apologize, I don't know the numbers off
That's
the top
okay.
of my head, I believe it goes down to $75 a visit if you do
Okay.
10.
okay. Well, all right, since I really don't know, why don't I do the discovery thing?
Yeah,
And
definitely.
so I did send an email because I didn't know I could chat. So I sent an email, said, please contact me because I want to do
Sure.
the consult. But I guess I actually will do the discovery and have you guys look at it that way.
Let me,
Okay.
I'm gonna roll you with me, and you're on a little cart here, so I'm gonna roll you up and see what if they can, I don't know if they. Have you
They
guys
can call me, they can call
yeah,
me
can you call
tomorrow.
Janet right now? Yes. So who, are you gonna call her, Hannah? Yep, Hannah's gonna call you right now. So I'm gonna
Okay.
click off of here. She's gonna call you and get you set up for that discovery.
Okay, thank you. It was really good and informational.
Great. Thank you very
Okay.
much for the feedback. I
It's
appreciate it.
it's
And so-
hopeful that I won't have to have surgery.
Well, I can guarantee you, we're gonna do everything we can and give you every option
Yeah.
for you not to have it.
Okay, well, thank you, Julie. Nice meeting you.
Nice to meet you as well. Have a
Okay.
good night.
All right, bye.
Bye.
Bye-bye.